Asmita, shall I start? Okay. So good evening to all of you. We'll start with the short case first. First is an ultra short case. It's happening. Okay. Is my screen seen? Am I audible to you?
Yes, yes.
Yes, sir.
Okay. Right, we'll start.
Yes.
Yeah, okay. We'll start with the short case first. This is a story of a 60-year-old lady. She complains of inability to open her eyes when awakening from sleep for the last 6 months. The inability may persist even up to 5 minutes. Sometimes she could open one eye, after which she could open the other eye. Once she voluntarily elevates the eyelids, she has no further problem in opening the eyes subsequently. This is the video of the patient. This is a home video which is taken and given to me. She is unable to open her eyes on awakening. She is awake, but unable to open her eyes bilaterally. She is trying to open, but not possible. She managed to open right a little bit. Then after some time, she is able to open both eyes. Okay, now she is able to open both eyes. She has not become perfectly normal. Still after some time, she is able to both eyes. So what is the diagnosis in this case?
Apraxia.
No, it's not. It's only on awakening from the sleep. Not present at time. All other times she's normal.
Could be blepharospasm also, sir.
Again, why should it occur only on awakening from sleep?
Lambert-Eaton syndrome.
No, only at that time. No, that otherwise she's perfectly normal. When she gets up in the morning, she gets this problem.
Paramyotonia, sir.
No, this is a very simple condition called awakening ptosis. This is a very benign condition. I have seen 2 more cases also. The only complaint is that she could not open the eyes in the morning hours. After some days, she could open, otherwise all right. If she tries to open voluntarily, then subsequently she could do that. It's a rare condition characterized by a transient inability to open one or both eyes upon awakening from sleep. The ptosis resolves with mechanical elevation of the eyelids. The patients awake from sleep are unable to open their eyes voluntarily, yet are able to forcefully open their eyelids with their fingers, after which the volitional control of the eyelid opening would be regained. It might represent a typical form of apraxial eyelid opening, or alternatively a focal variant of sleep paralysis, that is, persistence of sleep-related muscular atonia into wakefulness, but only confined to the eyelid muscles. Anyway, we do not know the explanation, but it's a transient phenomenon seen on awakening from sleep. So that's all regarding the first short case. Any questions on that case?
But there is spasm of the lower eyelid also, no, sir? Well, try to open.
Right, what you said is correct. They also some spasm is there. So the entity is called awakening ptosis, but there may be that somebody in the explanation also they kept the possibility of a blepharospasm also.
So anything for evaluation, sir?
No need. It does not take any evaluation. Nothing.
What is the treatment, sir?
No treatment is required. Only thing she can voluntarily elevate and she can become all right. Only lasts for a few minutes and then subsides. Otherwise, rest of the day she is all right. It's well described in literature. Again, I am not showing that various slides and the details are there, but in the interest of time, I skipped those things. Okay, in fact, this particular case I had shown some time back, but I brought this case with relevance to another case that is going to be discussed now. Shall I go to the next case? Okay, this is a story of a 70-year-old lady. This is given by Dr. Anis, who works with me in Travancore City. This 70-year-old lady was brought to the hospital with a complaint that she could not open her both eyes on awakening. No headache or any other complaints. She could walk normally except for the difficulty caused by the ptosis. No complaints prior to that. After a few hours, she could open a little bit and could see only legs of the people standing in front of her because she's unable to open her eyes totally. No history of any diplopia. The case was seen by my colleague and the photo was shown in the next slide. This is the photo of the patient with the bilateral ptosis. She did not complain of diplopia at all. So suspecting in myasthenia, did an ice pack test, which is negative, which is not improvement was seen with ice pack test. I had seen her on the third day. By this time, her ptosis has mildly improved, but she could open little better but better after closing the eyes for some time. That's what she told. She remains it closed for some time, then open. She's able to little more open better. There is no diplopia, no pain in the eyes, and this is the video when I saw the patient. I was going to look up. Looking down. I'll show the next part of the video. I'm looking to the left side. Right. Close it tightly. Then I made her open the eyelids with the left hand. Look for the ocular movements. Looking up. Looking down. Left. Right. Left. Down. Up. Pupil was normal, reacting to light. No asymmetry of the pupil. Again looking to the right side. Steam light. To the left side. Yes. Come to the rest examination. Motor system, sensory system, everything is normal. The reflexes were all normal. Lambda downgoing, gait normal. So, what is likely diagnosis in this patient?
Any myotonia?
No myotonia, clinical myotonia. In fact, it appeared like a myotonia because after closing, we find some difficulty in opening. But it all occurred on one day. It was never before. She was perfectly all right prior to that.
Stroke.
Pardon?
Stroke involving the diabetic population.
I didn't get you. You mean a stroke involving?
Nucleus of the levator population, central midline nucleus of the.
That's a good possibility, correct? But only ptosis, nothing else. Bilateral. She has no other complaint. Okay, so this could be myasthenia. In fact, the patient was examined once again, since my colleague Dr. Anis had suspected right adduction failure. So examine the patient once again in detail because I did not pick up the reduction failure initially. On examination, he's got elevation is okay, little bit restricted. Downward movement is also okay. Right side is okay. Left side, the right eye, there is a failure of adduction on the right eye. Initially, it was not very obvious. Now it has become obvious. She is telling no diplopia. I asked whether she is double. She is not saying double. The extreme gaze, left legs also may be affected or right abduction also may be affected. Not very sure about it. Middle rectus restriction is definite. There is some restriction of abduction on the right side as well. Left side also seems mild restriction of the abduction. Convergence was defective. So re-examination, there was not only right direction failure, which I missed earlier, but also partial restriction of abduction of both eyes. That may be there or may not be there, but there seems to be the eye is not going to the extreme to the left or the right. Still, there was no complaint of diplopia. So, what will be suspect and what test you would like to do?
Convergence for normal, sir.
Myasthenias.
Could be myasthenia. Agreed. Anything else?
It could be a stroke involving the nucleus and the right MLS.
Yeah, very good. That's a good possibility. Okay. So, is there anything odd for myasthenia? Is that the odd point? Myasthenia is that this occurred on the awakening in the morning. Usually, myasthenic ptosis occurs later in the evening. This is she noticed on the awakening in the morning and become less after some time. So it makes less likely for a myasthenia. But still, that possibility still remains because its pupil is paired, extraocular muscles involvement. See, something called a early morning paralysis, no, some snake bite and all can produce minor rejection abnormality described in North India. So patient was planned for an MRI and neostigmine test because considering the possibility of some lesion in the brain. So MRI was done. So this is the MRI. This is the T2 weighted. That's an old infarct there on the right coronal radiata. This is the coronal cut. This is the flare. This is the diffusion. This is the T1 weighted sequence. That shows a hyperdense lesion on the anterior to the midbrain. See, anterior to the midbrain on the right side. Okay, encroaching up to the midline on the opposite side. Then this is a T1 sag. Again, you can find out that deep and hyperdense in the interpedunclar fossa. This is a cis sequence. That is the Lesion is hypo-intensely. You can see the lesion anterior to the midbrain there. That is the C sequence. That is the lesion which is seen there, which appeared hyperintense in T1 weighted sequence. This is GRE sequence, which shows some blooming all around that particular lesion. So it's a chemical shift artifact. I'll tell you what is a shift. I think we shall later on. This STWA sequence again shows that blooming around that lesion. So I'll tell you something about the chemical shift artifact. There are two types, type 1 and type 2. Type 1 in the MRI, the spin echo sequence and the gradient echo sequence may demonstrate chemical shift, misregistration and mismapping. I do not know what it means. Anyway, it shows as a bright band on one side and a dark band on the other side of the fat soft tissue interface. This occurs in the interface between fat and a low intensity structure like water. Like how this particular patient had fat adjoining the CSF. That will produce this kind of a chemical shift artifact. The type 2 chemical shift artifact is the one which is seen in our patient. The other is called India ink artifact or black boundary artifact. Just like a black boundary on the right side. This artifact causes a black line in all directions of the fat-water interfaces in gradient sequence. Now, this is CT was done to find out what is the nature of the lesion. Shows there's a fat there. You can see the fat density in the anterior part of the. You can see the CSF anteriorly, but it is more hypodense than CSF in CT scan. That is this comparing T1 size showing hyperintensity and CT showing hypointensity. Proving that this is so this is the again continuing comparing with the lesion on the C sequence with that the T1 size. There is lesion and the T1 size is corresponding cut is shown by the yellow line. So contrast was done. That lesion was not contrast enhancing. So, what is the diagnosis?
Sir, is diffusion normal, sir?
That lesion look like a lipoma there. Any question? Diffusion normal? Is
The
it
brain
abnormal?
some hyperintensity is there in the diffusion. Is it normal, sir, in the midbrain?
Midbrain, okay. There's suspicion of it. That's correct. Let us see, review that thing later on. So there's a mass lesion there anterior to that.
That doesn't explain the ocular symptoms, no?
Very good. That's the answer I wanted from you. That lesion cannot explain the ocular symptoms because it could bilateral ptosis. The lesion is only on the right side. Moreover, that's something like a lipoma or a teratoma. That has been there for long. Why should it produce an acute onset of ptosis like that? So there is no reason why it should produce, unless there is hemorrhage occurred or something like that. So there is no reason to suspect what is that. There will be something else to cause the ptosis. So as you all suspected, this is the reason if nerve is a cytopathology, how can you get bilateral ptosis with a unilateral affection? And again, only one sided lesion cannot produce bilateral ptosis. So what else you need? Dedicated study of the brainstem, correct? Let us say the diffusion once again. Do you think some abnormality there in that area near some lesion there, no? Okay. There is some area somebody already pointed out, clinically also is suspected. So is it really convincing? What else you want to do? See, in brainstem infarct, never forget to do a coronal diffusion. Small infarct you may miss if you do only the axial section. So the coronal sequence was done. You can see the hyperintensity there coming out. Show them a little more clearly later on. See, that's hyperintensity there. See that one? It's exactly in the periaqueductal region anterior to the periaqueduct. So let's say adjust the window width and see how this appears. Density there. See, that is hyperdensity. So this is the one seen in the midbrain near the aqueduct. And that's also on the right side. And that is a culprit lesion and not the mass lesion anterior to the midbrain. You can see the corresponding cut here and this one. Angio was normal. So what is the final diagnosis? As he called said, it is an infarct affecting the nuclear third nerve on the right side. So very tricky presentation. He never complained of diplopia, no dizziness, nothing. Only complained to us bilateral. No diplopia, only complained to us unable to open the eyelids in the morning. Very odd presentation. Initially, somebody suspected stroke in this patient. I did not initially suspect stroke. Okay, any questions in that case?
Sir, in which part of the spine should we localize it? Because abduction is also affected, no, sir?
That's a little difficult. I'm not sure the abduction is really affected or not. If abduction is affected, we can explain by means of an associated involvement of the descending cortico-pondomycin pathway responsible for the gaze movement. So if there is a bilateral gaze palsy also, you can get the same thing. Okay, that may be the reason why it's got abduction failure on the both sides. But I'm not very sure about that thing. Whether it's really abduction involvement or the normal phenomena for this patient.
Upgaze was normal in this patient, sir.
No, upgaze is restricted, but you know what happened in old individual, you can have, the upgaze can be normally restricted in old individual. It can be up to 5 degrees only in older individual. Normally up to 15 degrees. It comes down to 5 degrees and the patient become old. So in older individual, to diagnose upgaze palsy is very difficult. Unless some other findings are there in this patient. Like an ataxia or something like that, it will be difficult to diagnose by just looking at the eye movement.
So is this the first MRI or a follow-up MRI showed the abnormality?
No, it's the first MRI.
Okay.
Because I was finding both MRI as well as neurostigmine test. So I thought I would do the MRI first and then neurostigmine. The MRI picked up the finding.
So usually in nuclear third nerve palsy, there will be contralateral upgaze restriction, no, sir. I mean, we
Yeah,
cannot test
you
it.
can. Yeah, and I'll tell you. You can have contralateral upward gaze palsy or even bilateral upward gaze palsy. Why? Because not gaze palsy, upward restriction. You can't call it gaze palsy because gaze restriction. Because suppose one-sided nuclear third nerve supplies the contralateral superior rectus muscle. So you expect a contralateral superior rectus paralysis. But what happened is that the opposite superior rectus subnucleus, suppose lesion is on the left side, the opposite superior subnucleus, the fibers from that superior rectus pass through cross to the opposite side and come to the left side. So because of the close proximity of the contralateral superior rectus fibers, that also get involved. So one-sided nuclear third nerve involvement can produce bilateral upward restriction of upward movement bilaterally. But it's always more prominent on the contralateral side.
Okay, sir.
I'll show another next week a classical case of nuclear third nerve. Next week I'll bring that case.
Can the fluorescence be unilateral?
Pardon?
Can the fluorescence be only on one side?
No, and if it is a nuclear third nerve, always ptosis is bilateral because there is only one nucleus for third nerve. If there is a unilateral ptosis, that means the vesicle is affected. After emanating from that caudal central nucleus, the vesicles are affected, then you can have unilateral ptosis, even in the brainstem lesion, anterior to that. Any questions? But curiously, this patient not anything, not even vertigo, nothing. A select small infarct in that location. Okay, shall I go to the next case? Okay, shall I go?
Yes.
Okay, right. Okay. This is a story of a 34-year-old male. His complaint started as fever and diarrhea 2 weeks back, which lasted for next 3 days. On the third day, he noticed a painful swelling on the right side of the upper part of the neck, which according to him improved with a massage and some tablets from the local hospital. 3 days later, he noticed pain and needle paresthesia in the middle two fingers of the left hand, as well as the middle part of the forearm on the left upper leg. So severe pain as well as paresthesia in the middle two fingers of the left hand, as well as the middle part of the forearm of the left upper leg. Almost the same time, he noticed pain and paresthesia of the right middle two fingers of the right hand as well. No history of any weakness or numbness of both the lower limbs. So this is a story. Fever and diarrhea 2 weeks back. Some swelling on the right side of the neck which subsided with massage. Then 3 days later, noticed pain and pins and paresthesia, pins and needle paresthesia in the middle two fingers. Then subsequently right middle two fingers and left medial forearm. So this examination finding. The shoulder abduction was normal, biceps was normal, triceps normal, reach extension was normal, finger extension is normal, finger flexion is also normal. Normal power. He complained of pain in the left hand. Then abductor and hallucis longus, abductor pollicis longus is normal. The small muscles were all normal except for the ADM. All the vascular is good power. See that? They're all normal power. It's also normal. Introsea were all normal. The only weakness is ADM on the left side. FDI was normal. Flexor pollicis longus, flexor pollicis brevis was normal. There is a brevis examination normal. Commons test was negative. There's also good power. Probably she may be mildly weak. Lower limb, hip flexion, dorsiflexion, etc. normal. But EHL was weak. That I could overcome. Mild weakness. This I could overcome that EHL. Reflexes, upper limb flexes normal. Finger flexion just elicited. Knee jacks were brisk bilaterally. Ankle jacks were absent. Ankle jacks are absent. He's not a diabetic. Plantar was flexed. Abdominal reflex was intact.
ഈ തൊടുന്ന ഇത് വ്യത്യാസമുണ്ട്
Now look very carefully, sensory. He's telling less on the medial aspect.
തോന്നുന്നു ഒരു ഡിഫറെൻ്റ് ആയിട്ട് തോന്നുന്നു ഇവിടെ നോർമലാണോ
That is decreased on the middle hand. That is normal on the thumb. Ask him to count 1. He's counting correctly, except he made mistake on the right hand middle part. Only one. Otherwise, all other areas he said correctly.
കമത്തി വെച്ച്
But the dorsal aspect he missed on the middle part. He did not count there. Or the lateral part, it is normal. There he missed. The distal forearm is able to feel the touch.
ഇത് വ്യത്യാസമുണ്ട്
The pain is decreased on the middle part of the palm.
മാറി നോർമൽ ആകുമ്പോൾ പറയണം സിദ്ധം മുഴുവൻ എവിടെ ഇരിക്കണം
Ask him when it becomes normal, you will point out the area. There it becomes normal. There it is normal.
ഇപ്പോൾ കുറവാണോ
Decrease there.
പറയണേ
Ask him when it becomes normal. There it becomes
കുറവാണോ നോർമൽ ആകുമ്പോൾ പറയണം
taking closer upward. He is paid up to the distal 1/3 of the forearm is also affected.
ഇതൊക്കെ നോർമലാണ്
The lateral part is normal.
ഇതും തമ്മിലോ ഇവിടെ കുറവാണോ
It's a link middle part is
കൂടി
decreased.
ഓട്ടം പറയണേ
I'll tell you when it becomes normal. The dorsal forearm up to the distal 1/3 it is affected.
വ്യത്യാസമുണ്ട് ഇനി കൂടിയ ഓട്ടം പറയണേ ശ്രദ്ധ മുഴുവൻ ഇവിടെ ഇരിക്കണേ
He'll tell you when it becomes there it becomes normal.
ഇപ്പൊ എന്തെങ്കിലും തോന്നുന്നുണ്ടോ ഒരു കിരിയിരിപ്പ്
Vibration is normal in the upper limb.
ഉണ്ടല്ലോ ഉണ്ടല്ലോ
All the fingers it is normal.
ഇപ്പൊ ഉണ്ടോ ഇപ്പോഴും ഉണ്ടല്ലോ ഈ വിരല് ഇപ്പോഴോ
Joints is impaired in the little and ring finger.
ഇപ്പോഴോ
Said correctly,
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴോ
it's impaired. He was not sure. Ring finger also is impaired. Middle finger correctly said.
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴേ
Said correctly.
ഇപ്പോഴേ
Right fourth finger normal. Little finger affected. He's not able to tell.
അത് കൂടുമ്പോൾ പറയണേ
The lower limb has got a pain level up to the ankle.
ഇതും ഒരേപോലെയാണോ വ്യത്യാസമുണ്ട്
Distally decreased.
മാറിയോ കൂടുമ്പോൾ പറയണം
It is decreased up to the lower 1/3 it is. Up to the lower 1/3 is decreased. There's area which is
ഇപ്പോഴേ
vibration is normal in the feet.
ഇപ്പോഴേ ഇപ്പോഴേ
Sorry, in a big toe it is impaired.
ശകല ഇപ്പോഴേ ഇപ്പോഴോ
JP is also impaired on both big toe.
ഇപ്പോഴോ ഇപ്പോഴോ
Not able to tell. Thrombus is negative. He could walk normally. He could walk on heel and toes. So on examination, motor system, upper limbs, no wasting, are all normal except for the weakness of abductor digiti minimi. Lower limb, no wasting. Weakness of both EHL. Other muscles are all normal. DTR, both upper limb, all normal. Fingerprint is also elicited. Both lower limb, both knee jerks were brisk. Both ankle jerks were absent. Abdomen reflex bilaterally normal. Plantar both flexor. The main finding in the sensory system, coming to the touch sensation, it is impaired over the both the dorsal aspect of medial hand on both sides and impaired over the medial forearm on the left side. This is of the dorsal aspect, that is where the touch sensation is impaired. Now coming to the pain, it's also maximally affected sensation. Left upper limb impaired over the medial two fingers or the palmar as well as dorsal aspect. Impaired over the medial forearm up to the elbow. Over the dorsal aspect, pain was impaired over the dorsal aspect of the medial part of the hand, which extends on the distal half of the distal forearm. The right upper limb impaired over the palmar and dorsal aspect of the medial two fingers. Impaired also over the dorsal part of the medial hand, medial part of the dorsal hand, and which extends up to the distal 1/3 of the dorsal forearm. The lower limb impaired over the distal 1/3 of both the lower limbs in a stocking distribution. So this is the lower limb sensory findings. So the pain loss, the ventral dorsal aspect. Now in the left hand, it is coming from the medially going up to the medial forearm, pain, let's say the pain loss. On the right hand, it is confined to the medial part of the one and a half fingers or 1.5 fingers and the middle part of the hand. On the dorsal aspect, not only the dorsal aspect of the hand and the medial part, extend to the distal aspect of the forearm. Same here on the right side. Right side is less, but it is extending to the forearm. So vibration is normal in the upper limb, impaired over the toes and lower limb. All other fingers, it is even the little finger, it is normal. Impaired pain over the little and so JPS impaired over the little and ring finger on the left hand, impaired over the little finger on the right hand, impaired over both big toes. Compass negative, gait normal. So, what's the slightly likely? If you want any clarification, I will tell the findings. This is serious sensory loss. He's not a person who bluffs. He's an army personnel. He says exactly correctly what our finding is. Consistent sensory loss.
It is multiple involvement, sir, of motor and
Right.
sensory nerves, sir, involving upper and lower limbs.
Very good.
The one is involvement of ulnar nerves, sir. There is motor and sensory ulnar nerves are involved.
Very good, very good.
And there is a patchy involvement of some cutaneous nerves also in view of the forearm is also affected up to the elbow, sir.
Right. The distal part is got a distal sensory loss also. The lower limb also.
Over the back of the forearm, sir, there is
Never thickening.
Hair thickening, I did not examine at that point of time. He had only 1 week history. He had history of fever and diarrhea preceding that.
AISP?
Okay, so it's a motor part is also affected, so you can consider CASMB or you can consider even a maximum variety of CADP you can consider.
Reflexes are
Or
preferred.
AADP. Pardon?
All reflexes are preferred except the angle depth, no?
Angle, yeah, correct. Except the angle, yeah, correct. What you said is correct.
So, and the right great toe extension was also weak, sir.
Great, both AHL were weak. Both ADM was weak. Abductor digiti were weak. Other muscles are all normal.
Yes, sir.
Even in the
Mononeurite
motor
is
arm also
multiplex.
patchy involvement is there.
Yeah, mononeurite is multiplex.
There is patchy involvement of the ulnar nerve also. Motors, ADM is affected, but the interfacial
Other
nucleus are
muscles
not
are
affected.
correct, perfect, correct. So all you think is a mononeurite is a multiplex, correct? Right? So what investigators like to do?
Nerve conduction studies.
Okay. This is a nerve conduction study. Distal latency is slightly prolonged in the median, right median nerve. Right ulnar is slightly prolonged, decreased latency. On the left ulnar is 3.8. And come to the lower limb, the amplitude is 2.3 in the left tibial. Velocity is decreased on the left tibial nerve. And coming to the sensory, both superficial peroneal and sural were all absent. And the ulnar also it is decreased, not totally absent.
FF,
Pardon? FA, this is FA. FA is, sorry, I forgot to show that thing. FA was prolonged in the left tibial, right ulnar, and left ulnar.
Lower limb sensory, only JPS is impaired. Otherwise, sensations are normal.
I didn't get you. Please,
In the lower limbs, all the slabs are absent. Sensory loss is not that.
No. In the lower limb, there is loss of pain and vibration and joint sense. Pain is lost below the lower one-third.
Okay,
And
sir.
JPS and vibration is impaired over the big toe. He never complained of that thing. On examination, he picked up.
So, predominantly sensory affection, both
Correct.
clinically and electrophysiologically.
Correct.
so surals are normal. No?
Surals are normal. Sural amplitude is and sural is potentially is absent. Sural potentially is absent.
Sir, acute polyradiculoneuropathy, probably involving the sensory and the motor, sir. So why
Correct.
did you tell that swelling in the right side of the neck, sir? Fever, diarrhea.
I don't know. That is what he told. But now we examine, there is nothing, no tenderness, no swelling, nothing. It lasted for only 2 days. He said he applied some massaging oil and then paracetamol and something. I don't know whether it's real swelling present or not, or he's telling like that, you will not know. These are the story the patient gives.
Okay, sir.
But
How
no,
was it?
nothing about
Temporal
that. Maybe
discussion of
pardon?
waves, sir. Waveform, sir.
Waveforms. Okay, waveform I did not take.
Okay, sir.
Okay, so what else you need? So this such was some demyelinating pathology because FAs are prolonged in a nerve where the distal latency is normal.
Total
Okay,
duration
what
is
else?
1 week.
CSF and
Duration
vascular profile.
duration is 7 days, 7 to 10 days.
And CSF study.
Vasculitis profile.
Okay, we can do that, right? So this is a blood count, CRP, random blood sugar. So in fact, in the doctor treating me, they took an MRI also, that's also normal. So what do you want to do? CSF?
Yes, sir.
Or
CSF.
anything? Okay, see this video once again. This is, I did not show the video again. See, if you take the sensory loss, it's correctly telling that it is lost in the half of the ring finger. That means it is the nerve pathology. It is not a root involvement at all. Radiculopathy will not produce that kind of a split sensory loss in the index finger. Sorry, ring finger. Now, what do you think? CSF, will it going to be help? Now, let us see. What is the peculiarity of this neuropathy? You have seen so many monoitis multiplex. What is the peculiarity of this type compared to other neuropathies?
Cutaneous nerves also affected, sir.
Very good. It's got a gross sensory loss with minimal motor weakness. That's point number one. You all saw that. Then it's got sensory loss. Narayana is so gross, but he is only weaknesses in the ATM. All of them, even the intrusion, everything is normal. And sensory loss in the both ulnar and left medial antebrachial cutaneous nerve. And the pain loss is more on the dorsum of the hand rather than the ventral aspect. See, if you look at all the things, the dorsal aspect of the pain loss is more than the ventral aspect. Even in the nerve itself, see, the dorsal aspect is more affected than the ventral aspect. That is another odd point. Most important point is the pain extends over the dorsal aspect of the forearm. That area is supplied with the radial nerve. But he has no weakness in the radial muscle supplied with the radial nerve. So what does it tell you? Now, taking this point, pardon? Yeah. What he said is correct. That means cutaneous nerves are also affected. So which is the type of monoitis multiplex where sensory is more affected, that too for pain, and do not respect the distribution of larger nerves? Because by putting in other words,
nonsense.
Very good. Somebody in the first time itself asked me whether did I look for a thickening of the nerves. So at this point of time, after examining completely, it was not fitting with an AD, but they started examining for the cutaneous thickened nerves. You can see God-like ulnar nerve there on the right side. And this is a gator auricular, now you can see that. So case of Hansen disease. He present acutely over 1 week's time and proceeded by diarrhea. That misled. They misled the initial doctor. So what I'm trying to say is a Hansen disease. Now, so after seeing this picture, I sent to the dermatologist, and the dermatologist picked up another interesting story. To her, she told that she divulged the past history of having taken treatment for Hansen disease 4 years back. Now, the question is that why it is acutely occurred may be a reaction. Need not necessarily be the recurrence of the Hansen's, maybe the reaction to the, that's what she was telling. Such patient may not require dapsone treatment, but require steroid. I do not know much about it. So, in fact, patient was sent to the initial doctor who treated for Hansen disease.
So what about the lower limb sensory? He had ankle reflex loss and EHL weakness. It cannot be explained by.
Yes, it can explain because Hansen disease can present these. Remember that it's also reaction to the Hansen. It need not be a Hansen itself. Classically, as you said, in Hansen disease, it affects the small fibers. The large fibers are preserved. And if so much so, the vibration, joint sense will be preserved, reflexes will be preserved. You got a cutaneous sensory loss, but those those functions mediate large fibers like posterior column sensation as well as the reflexes are all retained. But that's the old concept. But nowadays we know that Hansen disease can affect even ganglions, spinal cord, even large fibers, all can get affected. Because this I learned from Dr. Kadalkar. He has shown clearly the lepra bacilli in the ganglion and the sensory ganglion as well as in the spinal cord, the proximal nerves. So that can occur even in Hansen disease. That's not the classical presentation. I agree with you. Classical presentation is mainly cutaneous nerve affected. In the case of lepra, tuberculosis, they can affect multiple nerves get involved. and with no affection of the large fibers like posterior column, ribs, etc., but in and with all the case. See, here there is a digital sensory loss, can be due to handset, more likely due to the reaction to the handsets. Now, that is also the one which misled us initially. We thought of IV node post-infect only when you got this kind of a sensory patch of sensory loss, the dorsum of the forearm, and the minimal weakness, then only it struck to our mind that it is likely to be NHD.
Okay, sir.
Any questions?
So that swelling can be due to that reaction, type 1 reaction, swollen
It
nerve.
maybe, I don't know, because he's complaining of pain also, maybe that. But why should it subside? Maybe he must have received some steroid also, we do not know. He was treated with some tablets. Maybe he told only painkiller, but we do not know.
So here no swelling of the ulnar nerves or any dorsal-cutaneous nerve of ulnar nerve.
I looked for the dorsal cutaneous nerve, that was not thickened. The common fibular nerves were thickened, both ulnars were thickened, greater auricle was thickened, but dorsal cutaneous was not thickened. I looked for that.
Okay.
The touch loss didn't match exactly the pain loss. So can you call
Correct.
it dissociated sensory loss here?
No. Because here, no, the pain is out of proportionally affected, touch is minimally affected in that area. That's mainly because the touch is carried upon also by the large fibers. Here, what means that the small fibers are affected predominantly. To call dissociated, yes, it could be dissociated. In a sense, it's dissociated. But here, it is a neuropathy causing dissociation. In the sense that the small fibers are predominantly affected, the touch-carrying fibers and the proprioceptive fibers are less affected. In that way, it is. Pardon?
The snap from the ulnar nerve and from the dorsal-cutaneous nerve of ulnar nerve all were normal. So, dorsal-cutaneous nerve of dorsal-cutaneous nerve of ulnar nerve, branch of the ulnar nerve. There we can do the sensory snap, can check the snap. No? So that was also normal.
No, that snap was not done from that area. Only conversely it was done.
Okay.
From the little finger it was done.
Sir, one doubt, sir. Where
please.
for dissociated sensory loss, classic area when we suspect dissociated sensory loss, do we check the extremities or the central sternum or nape of the neck?
Okay. In the classical dissociated sensory loss described in intramedullary lesions of the spinal cord, like a syringomyelia. So it depends upon where the lesion sensory area is affected. Suppose it is affecting the CA-D1 segment, it may be confined only to the hand. If it is affecting from C5 to D1, all upper limb will be affected. If it's involved in the dorsal cord also, trunk will be affected. So the area what we look for is that there is no particular area to look for. Wherever he complains of sensory symptom, you have to look for. Even if it does not complain of sensory, but randomly touch each part, each dermatome, you have to look for any pain loss. It all depends. Suppose syringomyelia can extend from, say, C1 to conus, hollow cord syringomyelia. There it can be all throughout may be affected. But usually in the cervico-dorsal region, the cervical part, the half cave deformity, like from the neck to the upper limb up to the chest, one side is affected. That's a classical one. Sometimes it's bilaterally can be affected. That is a dissociative anesthesia.
So from the neck to the sternum, and also
it can be affected from the neck, trunk, upper part of the arm, middle part. It all depends upon which all segments are affected in the spinal cord.
Okay.
Suppose syringomyelia is extending from C1 to C4. You get only in the neck and up to the shoulder. The syringomyelia is extending from C2 to say C8. It may come up to the wrist, up to the D1. It can come up to the little finger and all. It will be affected.
Okay. Thank you.
It all depends upon the area the dermatomal area which is affected. There is one entity called reverse dissociative anesthesia, where the pain is preserved, but you get posterior column sensations are affected. That is seen in high cervical cord lesion, where the crossing fibers of the medial lemniscus is preferentially affected. Where the posterior column is affected, but pain is preserved. It's called reverse dissociative anesthesia.
Okay, thank you, sir.
So, any questions?
Sir, brisk knee in this patient, brisk knee reflexes.
That I can explain. Classically, in Hansen is also reflexes are brisk because the large fibers are preserved. Here, only the distal part, angle distance are absent. Any painful state can produce brisk reflexes. Okay. Shall I go to the next case?
Yes.
One more case, okay. This patient I saw when I went to Nepal. He gave imbalance while walking for the last 3 years. He's about 64-year-old man. Sorry, 54-year-old man. He had fallen 2 times while walking during the last 6 months. Dysarthria for the last 1 year. No positive family history. Other things are all negative. That's why I'm not mentioning about that. So this is the video of the patient. His eye movements were normal. There was no nystagmus.
Down. Okay.
Eye closure was normal.
Just open the
Lower
mouth
facial
with
muscles
the-
normal. But he had wasting of both half of the tongue and fasciculations. You can see the corrugated tongue and fasciculation of the tongue. Parrot movement normal.
Put out your tongue. Then
The movement was restricted on both sides.
this side. This side. Okay.
You can see the wasting of the
Wasting
tongue on the
wasting
surface.
is on the right side of the tongue. Bilaterally it is there. He has got a wasting. Udhar dekho, udhar.
Neck movements are normal.
Okay.
The limb tone power normal. Shoulder muscles are normal. Triceps normal. But he had incoordination of both upper limbs. Severe incoordination. And is going haywire.
ಏನು ತೊಂದರೆ ಆಗ್ತಾ ಇದೆ ನಿಮಗೆ?
Speech was dysarthric.
ಆಮೇಲೆ ಏನ್ ಕೆಲಸ ಮಾಡ್ತೀರಿ?
The lower limb tone was normal.
Okay, this was okay.
Power is normal.
Straight.
Knee extension is normal. But he had, see, he has got a club foot and a claw-feet deformity bilaterally. And his weakness of EHL and small muscles of the feet. You can make out the claw-feet deformity.
ಕೆಳಗೆ ದಬ್ಬಿ ಗಟ್ಟಿ ದಬ್ಬಿ ಕಾಲು ಹೊರಗಡೆ ಹೋಗ್ಬೇಕು.
Okay, come to the reflexes. Upper reflexes are all normal. Lower limb knee jacks are well visitable, but ankle jacks were absent.
Don't do like that.
Ankle jacks were absent. Plantar was indefinite. Suspicion of an upgoing tendon, but not very convincing.
Is he able to feel the pain?
ಅಲ್ಲಿ ಚುಚ್ಚಿದ್ ಗೊತ್ತಾಗ್ತಾ ಉಂಟಾ?
He is loss of pain, the
ಎರಡು
distal
ಸಮಾನ
one third of
ಉಂಟಾ?
the pain.
Okay. Okay.
ಜಾಸ್ತಿ ಮೇಲೆ ಕಡಿಮೆ ಕೆಳಗೆ ಜಾಸ್ತಿ ಆ ಥರ
लगता है चुन
Is
ತುಂಬಾ
equal.
ಇದೆಯಾ?
है तुम्हारे
Vibration is normal in the upper limb.
yes
Is present there,
ಅಲ್ಲ
but absent in the feet.
ಗೊತ್ತಾಗುದಿಲ್ಲ.
He's not feeling that.
ಈಗ
No.
ಗೊತ್ತಾಗುತ್ತೆ.
He's not feeling on the ankle and the toes.
ಇಲ್ಲ
Johnson's also impaired over the toes. Rombex positive, mildly positive. Not mildly, significantly positive. Ataxia is fault, he's got gait ataxia. Tandem walking is defective. So cranial ocular movement is normal, no nystagmus. Facial movement is normal, palatal movement normal. Tongue is wasted with fasciculation seen bilaterally. Motor upper limbs, normal tone and power of both upper limbs. Lower limb, pes cavus and clawfeet deformity. Tone normal, power proximal muscles normal. Angle dorsiflexion, plantar flexion normal. Weakness of both EHL and adductor hallucis. DTR all normal except for angle checks which are absent bilaterally. Sensory system, impaired vibration, GPS over both feet. Rombex positive, cerebellar, bilateral finger nose incoordination. Dysarthria is also there. Tandem walking is defective. So what do you think likely diagnosis in this patient? Site of lesion and probable diagnosis.
Any family history?
No family history.
Total duration is 3 years.
3 years duration. Ataxia 3 years, dysarthria 1.
Sorry,
The actual involvement is the peripheral neuropathy, cerebellar involvement.
Correct.
Findings in the tongue.
Yeah.
And
So he has got
pyramidal.
the pyramidal doubtful. We are not very sure. But one thing is certain, he has got a cerebellar, dysarthria is there, upper and lower limb incoordination is there. So that means he's got a cerebellar involvement. He has got a peripheral neuropathy, the distal sensory loss, absent angle jerk, and wasting of the muscles of the short muscles as well as weakness of the EHL. So he's got a peripheral neuropathy, motor sensory, most likely axonopathy. And he has got bilateral element tongue involved.
Gradually progressive over the last 3 years, a degenerative disease.
Right, perfect degenerative disease. The first point is that it does not fit. You cannot explain these findings with a single site ablation. If everything can be explained with a single site, you can still think of a possible. For example, only wasting of the tongue is there with cerebellar sense. You can think of a lesion of the foramen magnum and things like that. You can think on medullary lesion. You can think, but it's got a peripheral neuropathy. So that takes you away from a focal lesion. So you have to think of a system degeneration. So, like as you said, degenerative disease. Which degenerative disease you will think of?
SCA3, sir.
SCA3, put is wasting on the tongue like this. Anyway, so let's see which are the sites of lesion already you have said. So what investigation like to do?
MRI nerve conduction.
MRI.
Okay. MRI nerve conduction. Okay, do the MRI now. There is a T2 weighted to cerebellar atrophy. This is the flare. You can see some the hot cross band sign. See the hot cross band sign.
Slow. Cerebellum once again. See the cerebellar atrophy is there.
Cerebellar atrophy there.
Hyperintensity, they may be unrelated.
And this is that one. Like is hot cross band sign. Then this is the diffusion. It's SWI.
Deafness, which can occur in associated
Sir, is it SCA2, sir?
SCA2, does it what is wasting at the time? Very unlikely.
deafness.
SCA 36.
Yeah, correct. I'll come to that.
Associated
Okay, I'll come to that. Okay. So this is the brain. You can see the cerebellar atrophy is there. Okay. So cerebellar atrophy with hot cross band sign. So NCS shows evidence of peripheral neuropathy. This is the fibular conperon on the right side, not recorded. The other amplitude, left conperon is very low amplitude. So also TBL is very low amplitude. Distal part is affected. Typical peripheral neuropathy pattern. Tibialis anterior is of normal amplitude. Upper limb sensory decreased, upper limb sensory is decreased, but absent in the lower limb. So it's got a distal sensory motor neuropathy, mainly in the lower limb. I think FA volatile not recordable from the lower limb because of the low amplitude. I think I'll skip this away from my daughter. So other investigations, CPK normal, thyroid stimulating hormone normal. Okay, what is the diagnosis now? What test will you like to do?
Genetic.
SA panel, no? Patient cannot afford anything other than these are all done almost free for this patient. It's a poor, with a very poor social and economic background. So this is SCA36 somebody has pointed out. Because SCA36 not, this is because I had seen one such case before, only one case in the LP when Shaji was showing his CAN meeting, CAN teaching course, he showed one case of SCA36. At that time, I was not knowing about this condition. So the SCA30 is an autosomal dominant hereditary ataxia with late onset and slow progression that typically begins in the mid-adulthood. It presents cerebellar ataxia, sensory neural hearing loss, which this patient did not have, discrete motor neuron impairment, tongue atrophy with innervation, and discrete pyramidal signs. As the disease progresses, muscle atrophy occurs in the tongue, limbs, forearms, and hand. Tongue atrophy can make it difficult to swallow fluid. This is from the clinical CA6 from the Neurology journal. Age of onset is 53 plus minus 3.4 years. Most frequent symptoms being tongal ataxia, ataxic dysarthria, limb ataxia, hyperreflexia. Tongue fasciculation subsequent atrophy found in 71% of the cases, particularly in those with long duration. Skeletal muscle fascicular atrophy of the limbs is found in 57 cases. And people with CA have a normal lifespan. So that's the story of this patient. Okay, this is not a very challenging case. Only you must know that SCA can also present with wasting of the tongue.
This patient faults are secondary to ataxia or
most likely secondary. Both are contributing. Cerebellar sense as well as sensory motor neuropathy. Both will be responsible for his imbalance while walking. Combus is not that severely there, so most likely that he has got a sensory cerebellar ataxia is more causing his problem.
Dysarthria is combining
Yeah,
cerebellar plus element.
cerebellar plus element. There is definitely scanning speech is there, and as you said correctly, there is tongue atrophy that's also contributing to dysarthria.
So this hard cross bun sign is well described, sir, in 36.
Pardon?
Hard cross bun sign, sir. Is it
No,
described
no,
in FCA 36?
no. No, I specifically want to tell you this hot cross bun sign is not at all specific for anything. I have seen not only in MSA, in many other conditions, any case with brain atrophy, brainstem atrophy, I can see in this one. That is not specific for MSA at all.
Okay, sir.
The hard cross buns has been explained in SCAR 2 and 3.
Yeah, it's also discussed card 2 and 3. And there is an entity called a reverse hot cross bun sign also. I forgot that condition. Instead of hyperintensity, it becomes hypointense. I forgot that particular condition. It produces that.
Okay.
Okay, shall we close today? Any questions? Otherwise, we can wind.
So one question, sir, for that leprosy patient, though he had loss of ankle jack reflex and absent vibration JPS over the great toes, still his rhombox was negative. Why, sir?
Yeah, because to produce rhombogism, the level of sensation should be a little more gross, affecting the angle. If the JPS is only confined to the big toe per se, that will not produce positive rhombogism. Because what happens in peripheral neuropathy, what we examine is only the big toe. If its angle region is also not affected, they won't produce positive rhombogism.
Okay.
But most of the time, when you examine joint, we can't examine the joints into the angle that properly. Very difficult. So we're only checking the JPS of the big toe. Because if you imagine that if you cut off your big toe, you've taken off your big toe, nothing will happen to you. It not will imbalance. Right? If you cut off all your toes, again nothing will happen. But if the sensory loss is extended proximally up to the angled region, till then only the ataxia will occur.
Okay, sir.
So
So
in
reverse
BPA
hard
deficiency,
Pardon, reverse?
in BPA deficiency, can we get the reverse dissociation? Because of the posture, BPA deficiency, because of the posture form involvement, reverse dissociation is possible.
Yes, it's possible. Yeah, reverse is possible. There the posterior column is predominantly affected, pain is less affected. In fact, that is usually in the peripheral neuropathic distribution. So most of the peripheral large fiber neuropathy, it is large fibers are affected, posterior column is affected, pain is not affected. So there we do not usually use the term dissociate anesthesia, even though it's a dissociation. It only tells you which other fibers are affected. For example, in diabetic small fiber painful neuropathy, only pain fibers are affected. Large fibers are preserved. There we don't usually call reverse dissociate anesthesia. It all depends upon which fibers are affected. Usually in this term, dissociate anesthesia we call for lesions in and around the trunk. Due to the effect of the cord, we call this term dissociate anesthesia, not due to the peripheral neuropathy part.
Antispinal occlusion, there also we can use.
Yeah, that's also affecting the cord where the spinal thalamic tract is affected, posterior column is preserved. There's also some kind of a dissociate anesthesia.
In the lateral syndrome also in face and
Yes, lateral medullary syndrome also pain is affected.
Reverse hot cross buns in Wilson, sir.
Wilson, correct. Okay. I forgot the condition. Wilson disease, correct. There's one more condition, the reverse also, it's a metabolic encephalopathy. I don't know about metabolic. Hell, maybe Wilson itself.
Sir, what is reverse hot cross bun, sir?
It becomes, instead of the hyperintensity, you find hypointensity. That the triangle, usually the hyperintensity is the one caused the bun, no? The hot cross. The hot cross, instead of become hyperintense, become hypointense. Other area become hyperintense. I will tell you next class what is that condition. I will show the picture also next class.
Okay.
So next class, what crossment, reverse what crossment. One more thing I promised that nuclear thermodynamics. Okay. So shall we close? So happy Christmas, happy New Year to all of you.
Merry Christmas.
Same to you, sir. Same to you, sir.
Happy New Year.
Happy New Year, sir.
Happy New Year, sir.
Happy
you.
New Year. Happy
Merry
New Year.
Christmas, sir. Merry Christmas.
Merry Christmas. Thank you all. Thank you.
Good
We'll
night.
meet
Thank you, sir.
Thank you, sir.
Thank you. Thank you. Good night, sir. Good night, sir.
Good night. We'll meet next Tuesday.
Okay.
Okay, right. Okay, thank you. Bye.